There we go. The robot voice has told us that we are recording, so we are good to go. Welcome, everyone. Thank you all so much for popping into this session. To make sure you are in the correct session, this is titled Adolescent Suicidality, Interventions, Prevention, and Treatment. All right, so my name is Alex Zorowski. I'm the moderator today, so you'll only see me for this first portion at the very end and a little bit in the middle, just to give some housekeeping info here. So I'll go through that, then I'll go ahead and introduce our speaker today. So a bit of housekeeping in case you didn't catch it in the earlier sessions. Slides and any other materials will be available when we post the materials to our website. So that'll be a little later on, so we don't have those for you just yet. All sessions are being recorded, as you heard by the robot voice. We're going to post those recordings to Whova early next week, and then later on to the Washington Poison Center website. So we are not doing CEs this year. However, if you watch at least 5 sessions, that's either live or recorded, you'll be able to get a certificate of attendance. Again, and you have to watch those by September 15th. So 5 sessions by September 15th. We will be sending out a survey at the very end of the series, just to get your feedback, some ideas for next year, sessions, topics, speakers, so on and so forth. So please fill that out when you see it. And finally, please ask questions as you have them. If you have comments, I ask that you place those in the chat box, questions in the Q&A box. It's my job to monitor those as we go, and I will field those to Maribel when I can. All right, so let me introduce our speaker. So Maribel Camacho is a mental health therapist in the suicide prevention program at Seattle Children's Hospital. She started as a juvenile probation therapist in San Diego, California. Once in Seattle, Maribel became a co-occurring disorder therapist, treating youth with both substance use and mental health diagnoses. Her work at Seattle Children's includes both substance use assessments, a zero suicide responder, and orientation and training to suicide prevention practices and policies. She is passionate about decolonizing mental health, Hello Kitty, and iced coffees. I am with you there. All right, folks, so let me pass it on to Maribel. Maribel, it is all yours. Take it away.
Awesome. Thank you so much, Alex. Yeah, so nice to meet all of you virtually. Yeah, my name is Maribel Camacho, and I'm a therapist here at Seattle Children's. So we're going to be talking super broadly about suicide risk in adolescents, as well as what we're doing here at Seattle Children's to provide that care. So the term suicidality, I know it's kind of weird and kind of fancy, but it's a term kind of used to refer to broadly to suicidal ideation, suicidal behaviors, intent, plan, and death. So kind of a really broad term. And it kind of helps us really encompass everything that comes along with suicidal risk. For example, you can use it in a sentence like suicidality has increased in youth since the pandemic, or in another sentence, his suicidality stemmed from past trauma. So it's kind of a broad term, and we're looking at interventions, treatment, and prevention. I have no disclosures to report, so that's cool. And I do want to remind everyone to take care of yourself. We are going to be talking about suicide and suicide deaths. This is my everyday, and I talk about it super openly, very openly, and I understand that most people don't talk about this very openly. I remember my first day at Seattle Children's, the person orienting me kind of let me know that my everyday is a family's worst day ever. So I think that's super important for me to kind of keep in mind as I'm having these difficult conversations. So please do what you need to take care of yourself. Hug a pet or touch a tree, kind of do whatever you need. So we're going to be looking at national data and how that relates to Seattle Children's and our response to the suicidal risk that's happening a lot in our youth, and then treatment, prevention, interventions, as well as what can you do in your area wherever you serve children. So suicide is a national concern. Suicide is because it's the second leading cause of death among people 10 and 24-year-olds. So that is a lot of children at risk for suicidal ideation. So this is what we're talking about when you hear the phrase youth mental health crisis. Another kind of factor of that is the American Foundation for Suicide Prevention found here in Washington State that 83% of communities did not have enough mental health providers to serve its residents. So that's also kind of a big thing that leads to suicidal ideation, is people aren't able to receive treatment because there's not enough therapists out there. And then researchers looked at death data for the year 2020, so the beginning of the pandemic, and found suicide death among youth increased during the pandemic. And a year before that, in 2019, so way before the pandemic, that the Youth Risk Behavior Survey, so that's completed by U.S. high school students anonymously, they found that 1 in 5 kids indicated they seriously thought about suicide or seriously considered suicide. And then 1 out of 11 youths reported they did attempt suicide at least once 12 months prior to that. So the pandemic really increased depression, anxiety, and social isolation amongst youth. And that's all risk factors to suicidal ideation. So a really big concern nationally, as well as here in Washington. Right, so trends. Really not a fun slide, but a really important slide to kind of go over. So it's important that we look at trends when we look at suicide attempts and deaths. So under the attempts column, we see self-harm, cutting/piercing, and self-harm poisoning were within the top 10 causes of non-fatal emergency department visits in the United States, right? While under the death column here, and you see in both age ranges, under 18 and then between 18 and 24, we see the top means by people dying are by firearms and hanging, strangulation, and suffocation. So what does that tell us? So that means more people attempt by attempted overdose or cutting, while more people die by firearms and hanging and strangulation and suffocation. And this is super important for us to kind of be aware of, to kind of think about our public health messaging, as well as just our one-on-one interactions with family. So when I'm having the interaction with family, although me and the caregivers know the youth's attempt or youth's idea to kill themselves of taking 10 melatonin gummies, even though you and I both know that might not be lethal, we don't want kids to even attempt suicide. So that's why it's super important for us to kind of know the trends. And of course, in Washington, nationally, I'm sure this kind of statistic has been out that females attempt suicide more frequently, yet males died by suicide more often by a ratio of 4-1. So really not fun statistics, but it's really important for us to know. And 72% of firearm deaths were suicides. 51% of all suicides were by firearms. And again, it's really important for us to know, to kind of provide that psychoeducation to families on what we need to do to kind of prevent suicides in their community. Another not fun slide, but slides is super important to talk about. So overdose data of Washington, specifically hospitalization. So because we're in the overdose conference with poison control, we're going to be focusing on overdoses in our area. So this little visual display here, again, looks at non-fatal overdose hospitalization per rates of 100,000 people in King County. And Seattle Children's Hospital is located in King County in Washington. So as you can see, that little purple or darker purple line right here, so this represents ages 10 to 17. And as you can see, it definitely increased. And it increased by 39% in this kind of, time frame. So that's a lot. So, and we definitely saw that at Seattle Children's Hospitals in our emergency department, our inpatient units. So this is, again, helpful, not fun to see, but really helpful visual to see kind of what's happening with the overdoses here at Seattle Children's and in King County. So Seattle Children's has seen record-setting census for inpatients, intensive care units or ICUs, and emergency departments since the start of the pandemic. The ED surge code for youth mental health ended just last month. And I know we're 2023, we barely ended it. So surge codes is like a status kind of alert that that means that staff is experiencing operational challenges associated with the ongoing mental and behavioral health crisis, the high patient volumes in the emergency department. So a surge code is like all hands on deck. Like you might need to come to work earlier, you might need to stay a little bit later, you might need to prioritize certain clients. So that's what a surge code means. And again, that just ended last month. And that's not to say that they're not seeing high volumes in the emergency department. That's just saying we're not seeing the surge that we used to kind of several years back since the pandemic. And then Seattle Children's has named mental and behavioral health and suicide and injury prevention as top priorities. So like a lot of different hospitals, we set goals for ourselves in relation to kind of public health information, just like you saw the trend slides a few slides ago. So that kind of helps us inform what are going to be our top priorities, what we're going to allocate resources to, what we're going to really strengthen our workforce on. So yeah, but what does that actually mean when our hospital says we're going to make this a priority? So we now have the suicide prevention program, which is the one that I work under in the psychiatry and behavioral medicine departments, which is really great because we didn't have this before. We were all kind of conducting our own interventions, but now we're kind of getting a little bit more formalized, which is really great. As part of the suicide prevention program is adopting the zero suicide framework. So I don't know if any of you have heard of the zero suicide framework. It models a system-wide and organizational commitment to safer suicide care. It's promoted by the National Action Alliance for Suicide Prevention and provides comprehensive and evidence-based approach to suicide care. This model has provided a basis for the work that the suicide prevention program is conducting, and has 7 interconnected components that drive improvement policies and decisions, or the little ones right here, which is really great. So they're related to leadership and training and identifying those people at risk, engaging them, treating them, and transitioning them. So all this kind of cute little circle here, that's really helpful visual to see kind of what we're adopting under the suicide prevention program. We are part of the Zero Suicide Collaborative, which is really great, as with 15 other children's hospitals around the nation. So to really ensure our protocols and policies are in line with the Zero Suicide Framework and our peer institutions. A really key part of that research is that studies show that people who have died by suicide saw their healthcare provider within a year prior to their death. So that like research that they found, that statistic is really helpful for us to kind of start the zero suicide screening initiative here at Seattle Children's. So all kids 10 years and older are being screened for suicidal ideation, regardless of what appointment they're coming in for. So that's super important in the identifying part, the little green one right here, of we're going to try to catch them earlier and provide and do a screening and do an assessment and provide intervention and hopefully transition them to care. So yeah, that's what we're doing. That's a really big part of the Zero Suicide Framework that we're initiating, is the screening part. And you can visit Zero Suicide website for more information. It's really fun stuff if you want to start the Zero Suicide Framework in your own clinic or your school or anything like that. All right, so now that we talked about really sad suicide death data and trends and Seattle Children's commitment, we're talking about suicide care in regards to treatment, interventions, and prevention. All right. So what happens when someone overdoses? What happens when someone overdoses in an attempt to kill themselves? So this is very specific to suicidal ideation. This is not really talking about, oh, my lights turned off. This is not talking about when someone overdoses on substances, not an attempt to kill themselves, or like an opioid overdose or alcohol or anything like that. So right here on the right, you see what we call different levels of care, starting with the emergency department right here, and then the ICU, the inpatient unit, and then different levels for outpatient unit. So let's say there's a 16-year-old who got into a huge fight with his parents, and then he took a combination of Benadryl and tequila. When his mom found him, she called 911. He was transported to the emergency room, so they entered the hospital's care. And then he started having seizures, so then he was admitted medically into the PICU, or the pediatric ICU, where they're hospitalized for the physical and medical treatment of the overdose. So he stayed there for several days. Then after that, he was admitted to the inpatient mental health unit, where he received treatment in regards to the escalation that occurred. So that one's 24/7. After that, they are discharged to an intensive outpatient or partial hospitalization programs. There's a lot of different ones here in the state, as well as all over other states. And those are typically like 2 to 4 hours every day, and maybe like 3 to 7 days a week. So that could be like 10 hours to 15 or 20 hours a week. So they still get to go home every night, but they're not in an inpatient unit. So that's kind of that middle ground. So once they complete like up to 9 weeks, I heard there's 6 weeks, 4 weeks, 9 weeks. So it really depends on every program. So once he completed that 9 weeks, then he's discharged again to outpatient services and paired with a weekly therapist to continue the treatment of suicidal ideation and depression. So that's an example of how someone can move through our system or through systems, different levels of care after an intentional overdose to kill themselves. And I definitely have to say, this doesn't happen for every single kid or every single overdose or every single suicide attempt. Every child is different. All of their needs are different. Their level of acuity or risk level, we say acuity, is different. And so it depends. So sometimes the kid will go to the emergency department with a plan to overdose, but then are discharged into weekly services or outpatient services, or they start in outpatient services and then the therapist finds that their suicidal risk is very great and they send them to the emergency room, right? Or a family, goes to the emergency department and is pretty high risk, but the kid probably will not benefit from inpatient services. They might go to that middle ground intensive outpatient or partial hospitalization programs. And then they can kind of discharge to outpatient services, like a weekly therapy that you hear of. So again, it really depends on every kid. It really depends on their risk level and acuity level. And we're always trying to match that with the child and their needs. We don't want to send every single kid to inpatient services or residential treatment. And we definitely don't want to send all kids to intensive outpatient programs. So we are always evaluating the risk level and seeing what the patient might need. And sometimes a lot of intensive outpatient or partial hospitalization programs, this one right here, that's like up to 10 to like 20 hours a week maybe. A lot of times they serve multiple things, so co-occurring disorders. So a patient has depression or trauma and a substance use issue, or they have trauma and an eating disorder. So that's kind of when they have, again, co-occurring or different symptoms for a diagnosis at the same time. So kids are super, super sick. And so that's why the popularity of the intensive outpatient or partial hospitalization programs have really increased recently. Kids are suffering. Kids are very sick. Kids are experiencing a lot of symptoms. And so sometimes we call them IOPs or PHPs could be a really good choice for families. Or patients like sometimes have just random thoughts of suicide. They kind of come and go. I would never kill myself. They're probably going to be better paired with outpatient services, kind of a weekly therapist of someone, whoever would be a good fit. So again, these are different levels of care.
Hey, Maribel,
Yeah.
the connection kind of hiccuped there for just a second. Do you mind just repeating the last thing you said there?
Yeah, what did I say? So I said something about, so IOPs are different partial hospitalization programs. They became really popular recently because a lot of kids are super sick and are experiencing different diagnosable symptoms. So like eating disorders, substance use, and mood or behavioral disorders. And so they go to that high level of treatment. So it really depends on every kid and what their symptoms are and where they best fit onto the different levels of services here.
Perfect, thank you. That went through fine. So I think Zoom figured itself out.
Okay.
While you're on this slide, we have a question that I think fits with this portion well. Does intentional overdose treatment include connecting with the youth school counselor?
Ooh, great question. Not always. We would love to connect with the school counselor. So it really depends. So if there was an intentional overdose, they're probably seen at one of these, like the emergency department or medically admitted ICUs. Not always, because the school, that's if we're like reaching. We're always going to try to reach the assigned therapist, the continuity therapist out in their services. If there isn't one, then maybe we're always going to try to get them connected. If it kind of comes out through conversation that they really find the school counselor helpful, then we're going to try to talk to them. So it really depends on, again, every kid, but not always. It's not always guaranteed we're going to reach out to the school counselor. I do know for a lot of school districts, at least here in Washington, if a patient attempts during the school year, before getting them started in school again, I think we do try to coordinate with the school. I think some schools have very specific kind of conditions or requirements for the patient to return to school again. So that's kind of like sharing the safety plan, having maybe like an individualized like learning plan of how the patient can redo all the schoolwork that they missed because they were hospitalized. So I know there's that connection that we for sure do when a kid is in school, like during the school year. But that doesn't always happen. Sometimes school counselors don't get back to us. So we really try to make sure the community that the kid is going to go back to is going to be super supportive of them, whatever that looks like. If it's the school, if it's the agency that they're already paired with or anything like that. So we really just try to have that connection, but it's not always, not for every kid, I would say.
All right. Thank you, Maribel. And those who have asked other questions, I do see those. I'm going to do my best to ask those where they make the most sense in the presentation. Thank you.
Yeah. All right. So who kind of what happens? What happens in the individualized kind of levels of care? So these are different interventions, and a lot of things can happen. So I can see there's psych consultation, psychoeducation that happens, lethal means reduction or restriction, which we're going to talk about, risk assessment. And if you notice, a lot of the interventions kind of happen at all of the different levels of care. And that's the point, because all of these interventions are evidence-based and they've been proven to help with suicidal ideation. So these are just examples of kind of what here at Seattle Children's, what we do. I'm sure other hospitals do very similar things to in their specific different levels of care that they have. But like, for example, in the ICU, when a patient does overdose but is still not medically really clear to be discharged from there, there is therapists and psychologists and psychiatrists actually go to their room and still start conducting different interventions to kind of help the family be prepped for when they do discharge. So they're not just like sitting there hanging out. I know they're resting and they're recovering, but they're also kind of learning at the same time, because it's a super scary environment for them to be hospitalized after a suicide attempt. It's scary. There's beeping, everything. There's also a one-on-one watch, which is there for their safety, but it's super uncomfortable sometimes for families. So medical team really does their best to make sure they're getting treated for the physical symptoms, but also starting treatment very slowly for their mental health symptoms of what led to the suicide attempt. Right, and who performs all of these interventions? All of these different mental health professionals at Seattle Children's. There's a lot of them, and they're all over the hospital. So mental health evaluators are very specific to the emergency department. They're all licensed therapists and they evaluate mental health conditions. So it's not always an overdose. Sometimes it's just a plan. Sometimes it's behavioral issues that's kind of happening. So that's what mental health evaluators do. There's psychiatrists. So the difference between psychiatrists and a psychologist. Psychiatrists are the people that can prescribe medication. So they do kind of evals on that. Psychologists, they provide a lot of consultation to the mental health therapists like myself. We also have social workers, and all social workers here at Seattle Children's are licensed therapists. And they primarily, they're all over the hospital as well. There's case managers, family advocates, patient navigators, and social service specialists. So those are like a lot of the team that really makes sure the family is connected to care kind of after they leave Seattle Children's. So if they're going to an IOP or if they're going to outpatient services, a lot of times it's families' first time kind of navigating that process. It's confusing, it's weird, and why do I have to call at Tuesday at 8:30 in the morning to get services for my kids? So there's a lot of case management and like family advocacy that needs to happen to make sure that family is not dropped and connected to ongoing care, because that's a really big part of the zero suicide framework, is that transition, because a lot of kids kind of drop off, like they receive emergency services and then we're trying to get them connected to ongoing care, and it's really hard, and it's very specific because our requirements are very different from the other agencies' requirements, right? So that's what the case managers and family advocates are there for, to really make sure that bridge is secure and families start receiving care as soon as possible. And everyone, works together to ensure the patient is safe, number one, and they have the resources they need. All right, so that was treatments, and now we're going to go on to interventions and prevention techniques, excuse me. Both techniques are evidence-based, meaning they've been shown to be effective in preventing self-harm during escalation. So we have lethal means restriction or reduction and safety and crisis planning. These interventions and prevention techniques can be utilized for overdoses, self-harm, and suicide risk. It doesn't have to be very specific to overdose or anything like that. There's a lot of different intervention and prevention techniques, but lethal means restriction counseling and crisis and safety planning are standard tools that we use here at Seattle Children's Hospital. Okay. All right, so what is lethal means restriction, or what is lethal means reduction? So that's the idea that ways to prevent a suicidal crisis, to make sure that everything in the household is secure. So that's securing dangerous items. I know this sounds very like, well, duh, but sometimes families, they don't know that they don't need the Costco-sized Tylenol bottle in their house, right? And that's kind of the number one thing that we always provide that psychoeducation on to family, is all medications should be locked, not hidden, not in the top cabinet. My kid won't reach out, right? No, we need them locked. And we provide kind of safety devices, and I'll get into that in the next slide, but everything should be locked. And that includes the supplements, that includes the vitamins, that includes the gummies. Everything should be locked. As well as removing firearms from the home. This can get super uncomfortable in having a conversation with families of having firearms outside of the home. A lot of families are not willing to provide to put the firearms in another place. And we're not saying get rid of your firearm forever. We're just saying for right now, while your child is having the suicidal crisis, we need that firearm a different part of the house. Again, the safest part is outside of the house. If they're not willing to do that, what are they willing to do? And so we definitely encourage that triple safe storage of firearms and ammunition. So the handgun both has a trigger lock, cable lock, and is locked up, and the ammunition is locked up, and that's all in a safe. Beautiful. That's what we love. We want multiple levels. And we'll talk about that, why we want multiple levels for the firearm. And remember the trends that we talked about several slides ago. We want things locked up, and because that's what kids kind of used to, that's how people die the most, is firearms. So we want those to be locked up. And medications, that's how kids attempt the most. So that's why we want those secured. And then securing identified means. So if the child specifically said, I'm going to use my laptop charger to hang myself, or I'm going to, I don't know, swallow bleach to kill myself or something like that. So we're specifically going to secure that identified item, identified plan that the patient described. Or drowning or jumping. Drowning and jumping very specifically is kind of increasing supervision to kind of reduce their access to that. Sometimes, not for all kids, but sometimes you need to go a little step further, and that's securing potentially dangerous items, such as sharps, like knives or razors, and that could be common for kids who engage in non-suicidal self-injury dangerous behaviors. So we recommend we'll give a lockbox to secure that. Removing cleaning products from the home. That's again when a patient kind of identified that that's something that they would use to hurt themselves. So we would secure that from the household. And then sweeps for items that can be used for suffocation, strangulation, or hanging. I know that is the method kind of where a lot of patients die, where that is where a lot of patients die. So this is super hard to secure for sure. So I think that's in collaboration with the ongoing therapist of how can we continue to kind of monitor for suicidal ideation to make sure that everything's going to be safe in the household. There is a super helpful training for how to engage in this conversation. It's called CALM, the Counseling on Access to Lethal Means, and it's on the Zero Suicide website a few slides ago. So if you go to that website, this is a free training. It's about 2 hours, self-paced. You kind of go through it. There's a lot of little modules, and it gave me such confidence to have that conversation about securing your firearms and securing all medications in the household. I think that was a super big culture shock when I moved from California to Washington, how many people had firearms. This is an open carry state, and that was not something I was used to in California. And so after I took this training, I was like, wow, I can really have that straightforward conversation of where you're going to keep your firearms. Your daughter does know you keep it in your nightstand, and I know you have it not safe, right? So how to have that conversation. So I think anyone can have this conversation with a family or caregiver. So if you are a school counselor or if you are a primary care physician, I think it's super worth it to have this conversation or to do this training to at least kind of know what are the trends again, and then how to have that conversation with families. And again, we have the safety device program here at Seattle Children's, which we're super lucky to have, and that's all funded through donations, which is really great. We have firearm lock boxes. I should have brought one. They're not that big. They're enough for a firearm, but it can be used for anything. So for sharps and medications, you can probably use it. There's cable locks. So cable locks can be used for larger firearms that don't necessarily fit in a lockbox or safe. So that's a cable lock that kind of goes through the where the magazine goes and through the chamber, I believe. Kind of goes like that, and you lock it up. And trigger locks we have, so that can be used or that can fit most firearms. So if a household does have several firearms, let's give you 4 cable locks, let's give you 3 trigger locks and 10 lock boxes, right? It's just like, what can we do to reduce risk for this family because the patient is having suicidal ideation and has identified the firearm as a way that they would kill themselves. So we and a lot of different all of the different parts of the hospital at different levels of care provide these safety devices. And we train families on how to use the safety devices. So a big part of the program, the safety device program, is they found that families really trust medical providers to have that discussion. So that's super key to get that buy-in from families of you need to take the firearm to your brother's house or something like that, right? Is they trust their medical providers, which is really great. So we're in this really advantageous kind of like area of how can I have this conversation with this family? It's like, well, they're already going to listen to you because maybe you're wearing a white coat or because you're in the hospital. I know I'm not a medical provider, but I'm associated with medical providers because I'm in the hospital. So that's a super key part to the safety device program is we provide the education of how to provide this lockbox. So we sit down with the parents, we kick the kid out to another room, right? We sit down with the parents of like, this is how the trigger locker looks like, right? Or this is how the lockbox looks like. Let's open it, let's create a code, no birthdays. We always recommend safety devices that have an actual code, not a key, because you're going to lose that key or the kid's going to find that key. So all of that education we provide to families very willingly at all hours of the day. We provide these safety devices, which is really great. And the most important part is they're free for families. All right, now we're moving on, right, to safety plans. I don't know if you all have heard of safety plans. So they're a written document that details a plan to distract, self-soothe, and get help, and helps guide choices and actions during difficult situations to prevent someone from reaching a crisis. So it helps youth and caregivers prevent a small problem turning into a really big crisis. Like, for example, for a 16-year-old, they always get into argument with parents. That's not new, but why this time did it escalate to attempting to kill themselves by overdose, right? So safety plans are kind of designed to kind of, in that moment, what else can we do? Yeah, so his trigger, so we can kind of look in the bottom here on different options that kind of belong in safety plans. So the 16-year-old, this trigger was that I'm really triggered when I feel that my parents don't listen to me, right? My warning signs are I was rolling my eyes, I was swearing at them, I was super heated, my ears were hot, I was having a fist, right? Coping skills, maybe he could have dropped the subject with the parents, not continue to escalate it, maybe go for a walk outside, maybe go to the gym. Support from caregivers. I know this could be tricky in a lot of that conversation with caregivers. If your kid wants to engage in their coping skills of reading or riding their bike or going to the gym, let them. And they're not going to ask politely, right? They're just probably going to storm off and try to engage in a coping skill. So that's why we do recommend, when you're going to kind of do a safety plan with a family, that it is with a professional to kind of help have that conversation or guide that conversation. So support from caregivers, they let them engage in that safety skill, in their coping skill, I mean. People and resources to call. So that could be like, I call my grandma and I just say, Grandma, my mom is being super annoying, right? And just kind of be able to de-escalate and kind of talk about it if they want to. Or calling the coach, and whoever else could be a supportive person, maybe an adult sibling, of calling them, be like, can you believe mom, right? So any ways to kind of, again, de-escalate the situation. Sometimes reasons to live are included in safety plans. So that's when patients say, like, well, I want to be a doctor one day, or I want to go to college, or I want to move out. Like, I don't want to be with my family, and that's okay. What we're going to grab onto any kind of reason to live and kind of roll with it. Crisis lines. There's crisis lines. We're going to go over that towards the end. Nearby hospitals. If parents and caregivers really cannot maintain safety, there are nearby hospitals. We're always going to recommend secure transportation, such as ambulances. Therapists or agency crisis lines. So that's a lot of agencies now have their own crisis lines, which is really great. And like, the therapists that work at that agency kind of rotate a phone. So when you call your agency's crisis line, it's going to be by a therapist that you might be kind of aware of, but they're able to open your file and kind of go through your coping skills and grounding skills. And as well, parents, making the environment safe. Maybe we got a little loose with the medication. So if I notice my kid is super escalated and they go and engage in a skill, I go and lock up all the knives again, right? So these are all kind of little kind of parts that we have of a safety plan. All right. And there's a lot of different ones too, which is great. So there's safety plans, or crisis prevention plans, just a crisis plan, the Stanley and Brown safety plan, a safety arc, the escalation plan or de-escalation plan, the self-care plan. So here at Seattle Children's, the safety plan is integrated into the child's electronic medical record, which is really great. So any staff member can view it, refer to it, print it, and edit the plan. So if like they come from primary care and it's like, oh, do you still call your coach when you're feeling super escalated? No, I don't call that coach anymore. I'm not in sports. Okay, let me go and delete it and print this out for you again in your family or something, right? So we really want to have it like super part of the medical record, so that it's a normal conversation to bring up with the family. And the more specific you can get to a recent suicidal crisis, the more helpful the safety plan will be. And so that's how we do recommend that it's done with a professional, because they walk through that escalation. So these are examples of different safety plans that we use here in the hospital. Again, here's the safety arc, the CPP or crisis prevention worksheet, and then the escalation one that I know sometimes they use in the emergency department. So the goal is to identify the pattern and behavior and find ways to change it, right? Second goal, decrease access to potentially dangerous items. That's the thing that you're gonna hear me talk about a lot, is lethal means restriction or reduction, and as well as increase opportunities for intervention. So a kid is not always in crisis, as you see here from the crisis arc right here. What can we do to kind of make sure the crisis doesn't reach kind of the the top point where they use something to hurt themselves or overdose. What safety plans are not, they're not a solution to a crisis once the crisis already occurs. This is, again, the idea that we're not making something small turn into a really big crisis. So it's kind of like the pre to that happening. They're also not a guarantee that a crisis will not ensue, essentially. And they're not a safety contract either. So there are a lot of different things, but definitely not a safety contract. And there's also an app. I just looked it up, which is really great. There's an app for everything, because sometimes kids just take a photo, but then it's lost in the photo, right? So if they have an app, which is really great, they can, have it up. It's like, oh, I'm going to call my adult sister, my grandma. The phone number's right there, which is really great. So I haven't explored or downloaded the app to really explore, but apparently there is an app, which is really great. All right, so CARE at Seattle Children's, the Suicide Prevention Program, provides training and consultation to all staff members, whether it be safety planning or lethal means restriction counseling, or I really need a lockbox, can you run it to me? We provide that help and support to all staff members. And lethal means restriction and reduction counseling and crisis prevention and safety planning occur at all levels of care here at Seattle Children's. So again, in the emergency department, in the inpatient areas, there's a lot of inpatient areas, and in the outpatient areas as well. So we're always trying to provide the care to anyone who might need it. So what can you do? I know I read a lot of what therapists do or psychologists can do, but what can you do? Let's say you are a school counselor, or say you are a concerned grandma. Ask the question. We always recommend to ask very specifically, are you having thoughts about suicide? Are you thinking about killing yourself? Let's not dance around, are you thinking about hurting yourself? No, we definitely recommend asking the very specific question. Be there for them when they do answer of like, oh yeah, I am having thoughts, right? Help keep them safe. Maybe kind of helping be that conversation to their caregiver, helping facilitate that conversation with their caregivers of how can we keep them safe, right? Do you have any firearms at home? How are the medications stored in your home? How can we secure those, right? Help them connect. Just like, I think counseling might be really, really helpful, right? Let's find different agencies that provide therapy for you. And then follow up. Maybe a few weeks later, you see the kid again, or you see your grandson again, and it's like, hey, were you connected to a therapist? No, let's try again. Let me talk to your mom, or let me talk to your dad. You want to create protective environments. Maybe in a lot of kids are experiencing suicidal ideation who are LGBTQ plus. So if you create maybe home isn't really safe for them, but your space is safe for them, that's super important. I think I heard a statistic, if an LGBTQ child has at least one person they feel they can be themselves with and be honest with, I think it reduces their suicidal risk by 40% or something like that. So be that protected space for that child. Promote connectedness. Maybe it's not with you. I know it could be hard for parents of like, I want my son to talk to me. They're not going to want to talk to you, but who can we connect them to? Because it's pretty typical for teens not to want to talk to their parents. We get it. They're growing that independence. Parents sometimes could be a source of stress for them, right? But we really want them to be connected to somebody, right? Some adult, some helpful adult to them. Teach coping and problem solving skills. I know you're not all therapists, and that's okay, but there's a lot of different coping skills, like distress tolerance skills, like so mindfulness, right? And emotional regulation skills that could be super helpful for kids. And kids are always watching their adults in their life. So if you're kind of exemplifying distress tolerance skills or emotional regulation skills, you're seeing that, they're looking at that. So always kind of practice that in your own life to kind of teach the kid around you. Identify and support people at risk, but that's really important. So if you're noticing a kid isolating or skipping school, or not wanting to engage in XYZ, reaching out to them, saying, hey, what's going on? Lessen harm and prevent future risk. So that's, again, creating a safety plan or securing all the firearms and medications in the household. Strengthen economic support. This is more kind of for adults and their kind of risk factors for suicidal ideation. And strengthen access and delivery of suicide care. Also, Next month, woohoo, is Suicide Prevention Awareness Month. You can wear, do I have it? Yes, I do have it. You can wear a purple and teal ribbon that represents suicide prevention, which is really great. You can also join an Out of the Darkness walk, out of the darkness, to 1 Year You. I think they're happening all over the nation, which is great, and they're brought on by the American Foundation for Suicide Prevention. So you can go to their website and register for a walk near you, which is great. So a lot of them are happening next month and the month after that in October, which is really great. I believe the Seattle one, October 22nd. I'm going to that one, which is really great. You can also visit any one of these different websites. So 988 is the new national crisis line. 988, you can text it, you can call it, and you can chat it, which is really great. So if I'm in Seattle, Washington, if I dial 988, I'm connected to Crisis Connections, which is our kind of hub for that crisis kind of phone call support. But if you're like in Montana and you call 988, you're probably going to be directed through the phone or whatever to their kind of crisis connections, whatever that may be. So that's 988. We're always going to shout it out. You can go on their website. Their website is super cool. It has like, if I'm a parent, if I'm a concerned adult, if I'm a teacher, I want to promote Suicide Prevention Month in my school, right? They also either created or partner with the Be the One campaign, Be the One 2 campaign. So this is very specific to families, so not really like mental health counselors or anything like that. So it's like, how can I be there for my grandchild? How can I be there for my kid? How can I be there for my niece or nephew, and kind of help support them? So that one's a cool one for, again, families to kind of go through that. And then there's the crisis text line, which is 741-741. You can text home or help or anything, and then someone's going to be on there with you. And the bottom ones are very specific to Washington. Again, the Crisis Connections, which is here in King County, kind of what we use as our crisis hub. This is a mental health resource hub on our website at seattlechildrens.org. So if you're looking for psychoeducational handouts that are super helpful, or like the crisis prevention plan that I showed you a few slides ago, you can go onto that website and kind of look at the different handouts that are really helpful for the family. And we translate a lot of the handouts as well, because I know not everyone speaks or reads English. So we have a lot of the ones in different languages. And of course, the Poison Control Center if you want to know more information. And that's it from me. Thank you so much for letting me talk at y'all. I know I talked really fast, so I am ready for questions.
Perfect. Well, first, let me say thank you so much, Maribel. That was really excellent information. And as someone who works at the Washington Poison Center, it makes me very happy when folks integrate medication management, medication like locking strategies, and we get many calls on medication errors, whether they are intentional or unintentional. And so those lockbox strategies that Maribel walked through, they work for an array of situations. One of my managing directors once told me, for something to be truly child-proof, it's adult-proof. And so if you can get into it, if you just put it up high, they will, especially if you got a climber, like they can figure it out. All right, so I'm sorry, I interrupted you. Go ahead, Maribel.
Like they will find it for sure. So we want that locked, not just hidden or up high.
Absolutely. And we integrate that kind of messaging with like you had said, like over-the-counter medicines as well. All right, so we do have a couple questions. We got a range of them in terms of topics. So I'll start with the top. Let's see. So I have anecdotally heard that suicidal ideations can be triggered as early as elementary age. Is that true? And what can be done in the elementary school environment to prevent this or identify and support students and families who may already be facing this situation?
Yeah, I think there's kind of stories kind of being told of people who die by children who die by suicide as young as 4 years old. So they might not necessarily know that something's lethal. It's more kind of making my body stop working. So it's like a different conversation when you're assessing kind of for younger children. But that does happen. So that's why we are assessing starting at the age of 10 years old. I believe that's still elementary school. I know Rady Children's Hospital in San Diego is doing the Zero Suicide Initiative screening initiative starting at 8 years old. So of course, my opinion, the younger the better, right? But there's specific screeners that we have that's evidence-based for children, right? So we use here at Seattle Children's the ASQ that starts like 10 years old. I believe Rady Children's use a different screener. So it's like a specific way to ask the question for a children, depending on developmental age, of if they're feeling like they want to hurt themselves, if they're feeling they want to stop their body from working, if they're feeling they don't want to go home. So it's kind of assessments like that. I would say if like a youth in your school is experiencing kind of other maybe internal behaviors or kind of external behaviors, it's okay to ask the question. I'm always going to recommend to kind of have that conversation away from caregivers, because caregivers, I love them, but sometimes they don't manage their own emotions, right? And they're just like screaming, crying. I need you to have your moment somewhere else, right? So having that conversation with the kid of like, have you ever thought about this? Or kind of what's going on in your mind? Not necessarily tying the fact, because the younger kids don't know that dying is really permanent. So kind of assessing that part of it. So maybe it's just like, I don't want to go home, or it's just like, I'm super stressed out at home, or there's not enough food, or whatever that could be. So having that open conversation, even if it's not related to suicide or suicidal ideation, but you being a helpful person for them, that'll be helpful. So I think once there's a lot of risk factors kind of happening at school with external and internal behaviors, I think it's okay to, as a school counselor, a principal, a teacher, have that confidential kind of conversation, and then kind of bringing it to the caregivers, whatever caregivers, of like, hey, we're noticing this. I did ask these questions, and this could be helpful. Or what have you noticed in the home, right? Because at least in Washington, at 13 years old, they have that confidentiality as if they're 18. So anything younger than that, we can share with the caregivers. But older than that, then it's kind of different there. So yeah, so just be an open person for them, be there for them.
Thank you. Very, very helpful information. All right, very different question next. So has there been any research or evidence of adolescent suicide ideations being linked to prescription medication withdrawal? And they go on to say, an example scenario I am thinking about is that a patient is taken off of a medication they've been dependent on and been taken as a prescription for many years, and then all of a sudden the provider removes that medication cold turkey from the patient. Big question.
Yeah, I'm not a doctor, right? I do have my substance use, or I'm a chemical dependency license, but that's pretty different from kind of what's prescribed. I know that there is some evidence that it increases suicide ideation because it could kind of give children more energy to execute the suicidal plan. So that's why with the psychologist or with the psychiatrist or the primary care physician, they should be monitoring suicidal ideation when they increase the dosage, when they prescribe the dosage, right? When they're weaning off. I've always heard of providers kind of weaning off specific medications, but either way, it's pretty tricky time, and their distress tolerance is probably super low already, right? Maybe that medication didn't work, and then now we're kind of taking that off. Maybe it could, again, their ability to really engage in distress is really low. So that's why, like, that could be a thing. But again, I'm not a doctor. Talk to the doctor. I'm not sure. But either way, let's kind of build up that kid's ability to ask for help and maybe create a safety plan or something like that with that child.
Excellent, thank you. And thank you for positioning yourself within that as well. To clarify for folks too, I don't answer the poison helpline. I talk about it, but I don't answer it. So I understand having to position there with treatment advice. All right, a totally different question, very big one. How has social media influenced children who have thoughts of suicide?
Ooh, I'm sure a lot. I haven't read all the specific studies about it as well. I think what I'm seeing in my own feed is kind of our kind of therapeutic jargon kind of being used in everyday jargon, like that's traumatic, or I'm trauma bonding, or I'm triggered, right? That's a really big one as well. Which is great that people are kind of using that terminology, and we do know that the media has to be super, like media in general has to be super specific when there is like a high profile suicide, of not advertising, not describing the way that they killed themselves or something. So I think there's specific guidelines. And if you go to 988 website, 988 Lifeline, they also kind of describe kind of how to make that announcement or something if you need to. So I think, kids are on their phones a lot right now. And if they're seeing a lot of talk about death, or they're exploring talk about death for sure, I know there's websites unfortunately kind of dedicated to how to hurt yourself or something like that. Google's pretty smart, and it's just like, are you thinking about suicide, which is really great, and they just kind of pop up. But you can't really monitor that all the time. So if you can put kind of parent control on there, we do definitely recommend that for the younger kids. But still, when you have that conversation one-on-one with your child, like, is that an open conversation? We still want to strengthen that. They're going to get messages all over for the rest of their life, but we want to really strengthen kind of who they can go to for support.
Absolutely. Thank you. All right, another question here. How is our state doing with inpatient capacity for youth needing psych holds? I am in a rural and remote community, and it seems like we have a very hard time getting kids to bed when they need it.
Yeah, not great. It's really hard out here, right? I think also our inpatient unit used to hold 40 beds, but I think they're doing construction under some of the rooms because they haven't had reconstruction in a really long time. So we even kind of have decreased our capacity. So it's very hard. There's also clip beds that are kind of really popular, and a lot of kids are trying to get into those. It's very difficult. So if you can explore other kind of levels of care, like outpatient services, or that kind of middle one, partial hospitalization or intensive outpatient program, that might be the best one. Or I know some families have been sending children to other parts of the country so they can get services, because in Washington state as well, if a kid over 13 doesn't want services, they can literally walk out. And that could be very, very hard, especially for substance use. So yes, it's very difficult. If you're in a rural area, I feel for you. If you can find kind of online services, that can be helpful. But it's definitely hard here in Seattle Children's for our inpatient unit right now.
All right, thank you. Now I'll refresh a couple more times on my end to make sure I'm not missing any questions. We've got a few minutes left. Let's see. All right, no direct questions. Someone has just shared that they're struggling with this personally with someone in their family. So I hope that this session was helpful for you, participant. And there are quite a bit of resources out there. One last question I will ask, and we'll see if there's another question that pops up while I'm doing so. It's just if someone, just read the title of this, didn't have time to actually attend, and you had one takeaway for them, one action item to ask of them, what would that be?
Lock up your medications and your firearms. That's my number one recommendations at all times. Just lock it up. That's what you can do. That's sometimes the easiest thing that you can do, as opposed to getting your child kind of care, but just lock up all the potentially dangerous items in your household.
Right, perfect. Thank you. I'm going to do one final refresh, and if there's not an additional question or comment, we can go ahead and end just a couple minutes early. We're getting some thank yous in the chat box, so thank you for being here and doing that. You got someone saying that your Seattle Children's family has been watching and rooting you on, so bravo. Now, folks, after we end the session, Whova's still going to keep this open, so you can ask questions after we go ahead and end the actual webinar. We at the Poison Center are going to do our best to moderate those, and if there's a question we need to pull Mary Bell back into, we'll shoot her an email and keep that conversation going. We don't want this to be a one and done kind of thing.
For sure.
Now, Mary Bell, is there anything you'd like to share before we go ahead and wrap up?
Just thank you so much for attending this. I can tell that a lot of people are really dedicated to the care of the kids in the state and just outside of the state. So thank you so much for joining. And I hope, again, this is going to be available on their website. You can go on there and kind of use the slides made for your clinic. But thank you so much for joining.
Excellent. I couldn't have said it better myself. Thank you so much, Mary Bell. Thank you so much, attendees, and have a great rest of your afternoon. Bye, everyone.